Well, good afternoon, everyone. Thanks, Jim, for that introduction. Let me be another voice welcoming you to the great state of Tennessee. You know, the volunteer state has absolutely hit it out of the park. And I am biased, I admit, but how about that lowest per capita debt in the nation? And one of the top job producers in the whole country. And by the way, if anybody here knows how to coach football, see me after this. We do have a small need, but I hope you'll go out and sample the fun that Nashville has to offer. Maybe catch a Preds game, or while you're here, see some of those great music venues and sample some of our great cuisine. I spoke to this group several years ago, and that makes me think, okay, what war story did I tell? I got to make sure I remember that. But also, most of you as state legislators and elected officials, you're involved in the debate on health care. So again, the issue for me is knowing my audience, which reminds me of a story from back when I was in the Army. I was a scout platoon leader of an infantry battalion. And in that role, I got to do aerial reconnaissance. And one day we were training on aerial reconnaissance. And let me just say, aerial reconnaissance is where the helicopter flies right at the nap of the ground. You're flying through the trees at high speed. You're down on the river. You're up over the hills. And it's the best roller coaster ride on the planet. And I had this new soldier who had just been selected to be in the scout platoon. So he was very proud of himself. He felt very good about being selected to be in the scout platoon. And so I went to the pilot that day and I said, you know, I'll give you a case of your favorite beverage if you can make this guy toss his cookies. And the pilot was all for it. We take off on the mission and the pilot gives it 110%. And I look back to see if we've had success, and sure enough, the new soldier had lost his cookies. But much to my surprise, or I guess I should say, much to my demise, my company commander, my boss, had gotten on the aircraft and he'd lost his cookies too. So I wound up buying 2 cases of beer that day. But know your audience, know who's with you, and I'll try to do that as I go through my talk today. Before I launch into a talk on healthcare, though, I want to tell you just a few things about myself and my experiences in the Army as a physician. I watched a healthcare system operate where price was essentially zero. Supply was fixed, and the demand greatly exceeded the supply. On the far end of that extreme is the veterans' healthcare system. My undergraduate degree is from West Point, and it's in economics. Halfway through my career in the Army, they sent me to medical school. I then served as a special operations flight surgeon where supply exceeded demand. And then I came home and ran an emergency medicine department in an Army hospital where demand greatly exceeded the supply. After getting out of the Army, I founded a healthcare company, as Jim mentioned, running emergency departments, and we wound up, by the time I stepped away from the company, in 50-plus emergency departments in 11 states with about 1,000 providers. I say that to say this, I get the economics of healthcare, but I also get the doctor-patient relationship. And while I can argue that our healthcare system is still the best in the world, our system is in crisis. I don't have to tell you that the Affordable Care Act has had a devastating impact on small businesses, increasing the cost of operations and making competition for labor extremely challenging for those small businesses when they're competing against large companies that don't have to purchase health care through an exchange. The ACA has been a travesty. Far too many American counties are sitting with a single insurance provider, essentially killing the choice that was promised when the bill was passed. Numerous proposals have attempted to solve the crisis, but none really addresses the crux of the issue. The real issue is the human response to incentives. In a system where price is masked, like our current third-party payer system, the incentive is to spend. That's why inflation in healthcare has been twice the average inflation in the rest of the economy ever since the third-party payer system was put in place. We see just the opposite activity with health savings accounts, HSAs. But it proves the same point. In HSAs, consumption of healthcare has been decreased anywhere from 9 to 11%, depending on which study you read. Skin in the game changes people's behavior. Another problem is, of course, the government fixing the price. The current system has led to massive cost shifting because the federal government has set price below the market equilibrium point. Cost shifting creates entire segments of our healthcare economy where people simply can't afford healthcare. As costs are shifted, expenses to the health insurance companies increase. As their expenses increase, their price increases. As their price increases, fewer people can afford insurance. As fewer people can afford insurance, the pool of purchasers decreases, the price has to increase, requiring fewer people who can afford insurance. And it just completes the death spiral. Essentially, that's what's happened with Obamacare. Cost shifting to unsubsidized individuals and small businesses. Every year, fewer people can afford it, the pool of purchasers decreases, and the price increases. They come to us every year asking for an increase, 30, 40, 50%. Anytime you have a price fixed below the market price, you get a demand that exceeds the supply. In economist terms, we call that a shortage. Just look at the single-payer systems in Europe and Canada. Care is delayed because the supply will never meet the demand when price is zero. To fix health care, you have got to get a free market back into health care. Thank you. Now, there are some people who believe that copays are going to fix it, but copays are not. They may decrease overutilization to some extent, but they don't create an environment where people shop for care. And I'll share an example. The company I founded, we also had a foundation. We sent physicians on medical mission trips, and we were taking a trip to Cambodia. I sent a group of doctors to a large teaching facility here in Nashville, to remain unnamed, and we were going to get all our shots, our immunizations, before we went over to Cambodia. The guys called me and said, "Hey, Mark, the cost of these shots is $750 per doctor." Now, this is money that we've raised in a not-for-profit organization, so I said, "Hold on, let me call around." I called several hospitals and found one that would do it for $150. But if my copay was $50 here, $50 here, $50 here, why would I ever waste my time shopping? Copays don't work. Some argue, though, that a free market won't work in health care, and I would submit to you they're wrong. Look at LASIK eye surgery. When LASIK eye surgery came out, it was like $6,000 an eye. And now you can get it, I saw an ad the other day, $250 an eye for LASIK eye surgery. And this is not some simple procedure. This is a laser shaving microns off the front of your cornea. A free market will work in healthcare when patients have some skin in the game. And that takes us back to the comment I made about HSAs. Decreased consumption when people have skin in the game. So the question then is, how do you create a free market for patients who are getting their health care paid for by the government? Well, the government already has a program in place that is supposed to do that. The food stamp program, or Supplemental Nutritional Assistance Program, SNAP, is where 35 million Americans get some degree of assistance to help them purchase food. While it is certainly in need of serious reform, aspects of that program have been a success. People who qualify are given a debit card that allows them to go and purchase the food that they desire. The market price for food remains unchanged for most part because the consumer is choosing how to allocate the resources. Now, I know there's fraud in the system, but that's mostly because of poor execution and not because of a flawed concept. Let me share how that can work in healthcare. In Tennessee, we pay about $6,000 per Medicaid patient. For certain, especially low-risk patient groups, what if we took, say, $1,000 and placed it into a debit card? We allowed that card to be used solely for health care at patients' primary care physicians, their pharmacy, and their local hospital. We take some of the remaining dollars and we purchase a catastrophic health care plan in the event that someone gets cancer or diabetes. And then we tell the patient, by the way, of this $1,000 on the card, whatever you don't spend, you get it back as an earned income credit at the end of the year. Now the Medicaid recipient has skin in the game. They're incentivized to shop. They're incentivized to save. Choice is placed back into the hands of the patient. As more people shop for care, a market price can be established, and overall costs will decrease. With more people paying for care and a price set by the market, cost shifting goes away. Let's go back to the data on health savings accounts. Remember, I said 9 to 11% decrease in the consumption of care when people were paying first dollar out of their pocket. If we decreased Medicaid funding in Tennessee of medical care by 11%, it would nearly pay for the expansion population with not a single dollar from the federal government. Or it would provide taxpayers a great break, or some combination of the two. Last year, Tennessee passed my joint resolution. It was signed by the governor, and TennCare requested a waiver to allow us to test this EBT concept in a pilot population. And you guessed it, we're still waiting on CMS to give us an answer. We must repeal the Affordable Care Act and return the money back to the states. One bill that has some great block granting components to it is, of course, Graham-Cassidy. Now, the beauty of Graham-Cassidy is, of course, that it does block grant money back to the states. And if we get that money, Tennessee, and I'm sure many of you will try innovative solutions just like this. Graham-Cassidy is not perfect. There are certainly some troublesome parts. But Bernie Sanders has, I believe, 16 co-sponsors to his massive socialist bid for universal health care. No one wants to wait 6 months for an MRI, Senator Sanders. Just say it. And for the skeptics, a friend of mine told me that in Canada, for an MRI of your knee, you wait 6 months. For an MRI for your dog in Canada, you can get it the next day, because they have a free market in veterinary care. Graham-Cassidy caps the growth by spending a little now to prevent us from actually getting to the intended outcome of Obamacare, and that's complete government control. Now, I don't mean to be an alarmist, but Graham-Cassidy, with some possible amendments, may be the last solution to keep us from universal health care. With dollars block granted to the states, we, the people in this room, can innovate. We can be those laboratories of democracy that our founders intended. And as a state legislator, I'm hoping that the block grant can be the camel's nose in the tent, ushering in block grants in other areas to give more control back to the states, control intended by our founding fathers. Thanks for the opportunity to share my idea of just one possible solution should the federal government grant us, the states, the opportunity to innovate. Thank you.
Please welcome back to the stage ALEC National Chairman, Senator Jim Buck.